My name is Quoc-Dien Trinh. I'm a urologist with a focus in prostate cancer at Brigham Women's Hospital and an associate professor of surgery at Harvard Medical School. Today, I will talk about our community outreach efforts in collaboration with the ADMETech Foundation. Here are my disclosures. So if I go straight to the take-home message, a lot of the work that our group and others have done is to really detect racial disparity in prostate cancer outcomes, a difference that we think is rooted in access to care differences between Black and white men. In more recent years, our research group and others have focused on trying to understand those disparities and trying to understand why men of color face significant barriers, whether it is transportation challenges or mistrust in receiving their care. And finally, today, I will talk to you about our early preliminary results in the outreach efforts that we have led in Massachusetts and beyond in New England. So racial disparities exist across a number of medical conditions, across different cancers. But what's interesting and concerning is that the racial gap in mortality for prostate cancer over the last few decades has either stagnated or potentially even been worse based on some of the data we have seen. The other thing that is interesting is that gap in mortality between Black and white men, well, we see it for potentially other cancers, but the gap is very pronounced for prostate cancer and not fully explained by biological differences. Some emerging data that has come out in the last few years, including this study by our group, shows that, yes, there is a significant gap in mortality between Black and white men presenting with prostate cancer. But when you start accounting for social determinants of health, receipt of treatment, receipt of timely treatment, those differences potentially go away to a point that in some quasi-simulated circumstances, potentially Black men do better. And I do want to point out that these are simulated circumstances because this is not real life. But what's very interesting is to find that this study and other studies using different sources of data have shown similar things. In another study by our group, we looked at differences between institutions and the treatment rate of Black and white men, and we found that there was a significant gap in 39% of institutions more likely to treat white men than Black men, and only 1% of institutions treating more Black men than white men. Is this because of the institution? Is this about the patients? Is it a little bit of both? It is something that is definitely worth digging a little bit more. The prostate cancer work group of the Massachusetts Department of Public Health, of which I am part of, looked into this question in the state of Massachusetts. The relevance of this question is that in Massachusetts, most people have health insurance through legislation that was instituted more than 2 decades ago. What's interesting is that even in the great state of Massachusetts, with quasi-full coverage of health insurance, Black men were 22% less likely to receive definitive care for prostate cancer, which raises questions about providing health insurance. Is that enough to allow access to care? But access to care is a very complicated topic and encompasses a number of different explanations or models. For one, one that we often hear about is affordability of care, and this is where health insurance makes a difference. But it also is a question about copays and other factors. But there are other factors that come into play when we try to understand access to care. These include things like acceptability. Does the patient trust the organization, this hospital where they are receiving care? And things like travel burden, which cannot be reduced simply to distance of travel, but also the resources necessary to travel. For example, traveling 2 miles down Route 9 is pretty simple to receive care west to east, getting into one of the academic medical centers. But traveling south up to north to receive care using public transportation in Boston is not understand access to care. We did a case study, and this was with the Department of Public Health, led by my. And as part of the stakeholder qualitative analysis, we found a number of important things. One is the mistrust in health systems men of color face when they are getting into care for prostate cancer. some of the academic medical centers in Boston, around Boston, may not be the places that are trustworthy in the eyes of communities of color. Another important factor was at a hospital level, there was a lot of confusion about how community outreach should happen and what is the responsibility of a large healthcare system like the one where I currently work. So what I have tried to show here is that access to care is a major driver of racial disparities in prostate cancer mortality. And the solution that we have devised here is the idea that by creating a comprehensive outreach program, we can make a difference in Massachusetts and beyond in New England. As part of this strategy, community engagement is very central. The idea of community engagement is that we are collaborating with community to identify and address key issues. There are different forms of community engagement that ranges from things like events that I will show that we have done, but it goes as far as to empowering patients through patient advisory board, which is also something that we have used as a strategy. The idea here is that community engagement is important to support the clinical care of underserved communities and really to empower these communities to be involved in devising solutions. The Mass General Brigham Prostate Cancer Outreach was born from the United Against Racism initiative of our parent organization. This is a project that I currently lead with my colleague from the MGH, Adam Feldman. And the mission here is to offer high quality, accessible, and affordable prostate cancer care to minority men. In creating this initiative, we work with a number of stakeholders to devise a go-to-market strategy. And as part of my presentation today, I do want to share with you some of the things that have made a huge difference. One of them is hiring a community health worker, because prostate cancer care is complicated. If you compare to colorectal cancer, whereas the diagnosis is very simple, somebody is due for screening, a primary care provider can directly order a colonoscopy, and the diagnosis is done through that single test. In the world of prostate cancer, patients are seeing primary care providers. They may or may not engage in shared decision-making. They may receive a PSA. They may receive a second PSA. They may decide to have an MRI done. And then they may have a referral to a urologist who may decide to do imaging, biomarkers, etc., and then eventually get an invasive procedure, a prostate biopsy, to get a diagnosis of prostate cancer. That whole process is complicated, and having a community health worker at the center of this, we believe, makes a huge difference in doing effective community outreach. Another thing that was hugely successful of this initiative is really creating and enabling a prostate cancer safety net. The idea of the safety net is that if a patient meets a number of criteria, an elevated PSA, not having a history of prostate cancer, and do not have appropriate follow-up, then these patients are flagged and sent to a community health worker who makes sure to call these patients back and make sure that they receive appropriate medical care. As you can imagine, a lot of men of color, a lot of men who do not speak English are part of those that we are able to flag in the safety net. Another extremely successful part of this initiative, and this is something that we are doing in collaboration with the AdmiTech Foundation, is holding community outreach events to really build trust in a non-threatening environment with communities of color. As I mentioned earlier, there is a level of mistrust between large academic medical centers in Boston and communities of color in New England. And by devising these events, we think that they're very important to rebuild that trust and potentially also obtain patient referrals. But the main goal here is to build trust, educate, and empower communities of color. These are some examples of these events that have been held across a number of settings, whether it's in the top right, a public library, in the bottom right, in the church in collaboration with FEN, one of our community partners. In the bottom in the middle here is an event that was held at a construction site, community fairs, etc. Here are some of the preliminary results of our initiative. We're talking about more than 400 patients seen. We're talking about 25% of elevated PSA referrals were diagnosed with cancer. More than 100 procedures were performed at Mass General Brigham. Obviously, the long-term outcomes are TBD, because prostate cancer is a disease that evolves slowly, and we will only know if we're making a difference in potentially 5 to 10 years. This is another example of our success, the efficacy of the safety net in reducing unfollowed abnormal PSAs. As I said earlier, in the early stage of the process, a lot of patients were part of the safety net, but as we are able to clear them and get appropriate follow-up for these men, the number of patients on the safety net has decreased dramatically over time. While we had a number of successes, there have been also a number of challenges. And there are many challenges that we encountered, some of them related to the COVID-19 pandemic and how it affected receipt of care and our effectiveness in holding patient engagement events, among many of the other barriers that we have faced. As we look forward, we also have to ask questions about how to maintain sustainability, and financial support is very, very high on that list. We receive annual support from the Unite Against Racism initiative of Mass General Brigham. We are lucky to be working with community partners, and that has been widely successful. But also what has been very important is securing research grants. For example, I have received the grant from the DoD, my colleague Alexander Cole as well, that leverages the Prostate Cancer Outreach Clinic and provides funding support for it. And also philanthropy has been something that has been very important to build out our outreach efforts. In terms of new directions, I have mentioned how the safety net has been mostly focused on elevated PSA, so early stage, even before the diagnosis at the level of screening. Well, we hope to expand the safety net across the whole spectrum of care, because as I said earlier, receiving a PSA test that is abnormal is only one step. There's many steps along the way, and there are many opportunities for patients to be lost to follow-up, and expanding that safety net as part of the next phase of the Uniting Against Racism grant is very high on our priority list. Why just restrict to prostate cancer? Obviously, our outreach clinic has been focused on prostate cancer because that is my clinical interest, but I'm happy to share that in the past year, we have expanded our access to not just the diagnosis of prostate cancer and elevated PSA, but across a broad range of conditions for urology. And this is something that we do at Brigham and Women's Faulkner Hospital under the leadership of Alex Berger, who is my colleague over there. So in closing, what I have tried to show here is that, yes, there's a lot of clinicians, a lot of researchers that have focused on generating evidence. We're talking about clinical trials and try to impact physician recommendations. And this is a conceptual model that was designed by Brent Holmbeck, the chair at on the MGH side. And there are also a lot of people have been working on policy, trying to understand how do we change policy to impact things like racial disparities and prostate cancer. But one would argue that if you are really interested in making a dent in things like social determinants of health, the community outreach effort is really what is needed. And I have tried to show here some of the early successes of our initiative, because I do believe, and many believe, that physicians have to be at the center of such initiative. Thank you for your time.